The difficulty of
hospitals. Okay, our network hospital. Juga. Makassar juga, no? Siap, bro. He's from Makassar.
From Makassar.
Yes, actually from Toraja. Toraja.
Okay.
Toraja, ya, sorry, Toraja.
Yeah. Okay.
Selamat datang bagi Bapak Ibu yang telah hadir melalui Zoom. Terima kasih atas waktu yang telah disediakan untuk menghadiri diskusi tentang kerjasama sistem registrasi kanker. Bersama kita telah hadir Mr. Leslie Mary dari International Agency for Research on Cancer (IARC) yang akan memaparkan tentang Global Initiative for Cancer Registry Collaboration. With us today we have Mr. Leslie Mary from the International Agency for Research on Cancer, who will present on the Global Initiative for Cancer Registry Collaboration. Thank you to all the participants who have joined us. We will now the opening ceremony. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Ladies and gentlemen, good morning and greetings to all of you. First and foremost, let us express our gratitude and praise the God Almighty for His blessings and guidance, which have granted us the opportunity to gather here for this important discussion. It is an honor and pleasure to warmly welcome Mr. Les Mary as the Global Project Manager from the Global Initiative for Cancer Registry Development, GICR, International Agency for Research on Cancer, who has kindly spared his valuable time to be with us today. We would like to extend our utmost appreciation to the Digital Transformation Office from the Ministry of Health, also the President Director of National Cancer Center, Darmais Cancer Hospital, Dr. Suko Wedimidito, together with Evelina Susana MD, Head of National Quality Control for Cancer Burden Data and Cancer Control Department, National Cancer Center Indonesia. We would also like to express our gratitude for the presence of Director of Referral Health Service, Director of Health Good Governance, Head of Data and Information Center from the Ministry of Health, Cancer Registry Team in Indonesia, also representative from each vertical hospital of the Ministry of Health and Provincial General Hospital throughout Indonesia, who have taken the time to participate in this event online. Today's discussion aims to explore and shape brilliant ideas regarding the development of a cancer registration system, an incredibly relevant and significant topic in the prevention, detection, and treatment of cancer in Indonesia. By bringing together competent and experienced speakers in their respective fields, we hope that this event can serve as a platform for productive interaction and collaboration, ultimately leading to the enhancement of an effective and efficient cancer registration system in our country. To begin our event, we would like to invite the President Director of National Cancer Center Indonesia, Darmais Cancer Hospital, Dr. Suko Wedimidito Mars, to deliver his opening remarks. To Dr. Suko Wedimidito, the floor is yours.
Yeah. Thank you, Odi. Honorable guest, Mr. Les Mary, welcome to Darmais Hospital. Yang saya hormati juga teman-teman atau pimpinan dari Kementerian Kesehatan, ada dari DPO, kemudian direktorat di Yankes, saya kira begitu, kemudian direksi Rumah Sakit Kanker Darmais, dan juga teman-teman Dr. Evelyn khususnya terkait dengan data beban kanker di Indonesia. So first of all, I would like to express my warm welcome to you, Les Mary, because as you know that cancer registry is not a simple simple way to collect data from many hospitals in Indonesia. We have to have a kind of strategy how to collect this. DTO ada di sini, so there are digital transformation officer who can collaborate with Darmais and other hospital to make the system in collecting data cancer is easier for everybody and for every hospital in Indonesia. So we hope in the future, regarding the strategy of Ministry of Health, transformation of health in Indonesia, the data also one of our priority that's very important as a base for policy in Indonesia. So before we continue discussing with you, I would like to say hello to participant here in di dalam Zoom. Selamat siang Bapak Ibu sekalian. All participant in Zoom is a hospital who already have pelatihan. Training about cancer registry. Jadi Bapak Ibu sekalian, terima kasih atas hadirnya pada hari ini. Mungkin Bapak Ibu bertanya-tanya kenapa kami mengundang Bapak Ibu semua terkait dengan kehadiran Mr. Lesmeri di Rumah Sakit Kanker Darmais ini. Bapak Ibu, kita semua tentu memahami bahwa transformasi layanan kesehatan di Indonesia ini berjalan terus dengan sangat cepat, sehingga kita harus melakukan adaptasi terhadap program-program yang mengikuti transformasi tersebut. Kita ketahui juga bahwa ada prioritas seperti penyakit jantung, stroke, dan salah satunya kanker, itu menjadi prioritas untuk dikembangkan di dalam pelayanan. Saya ingin mengingatkan kepada Bapak Ibu semua yang hadir di sini bahwa di dalam menyelenggarakan kanker, setidaknya kita harus selain melengkapi dari alat atau sarana prasarana dan SDM, tetapi yang paling penting adalah bagaimana kita bisa menjalankan 7 program yang sudah dicanangkan oleh WHO terkait dengan layanan kanker. Saya boleh ingatkan lagi, yang pertama promotif preventif. Kegiatan promotif preventif terkait kanker itu harus berjalan di rumah sakit Bapak Ibu. Nah, tolong dicek lagi sambil kita Zoom, dicek promotif preventifnya ada enggak. Ya. Yang kedua adalah deteksi dini. Deteksi dini kanker itu juga menjadi hal yang penting. Cek lagi apakah kegiatan deteksi dini sudah berjalan atau belum. Ini prosesnya jalan terus nih. Kalau Bapak Ibu cek belum ada, berarti nanti suatu saat pasti akan ketinggalan, gitu ya. Kita akan melakukan kegiatan gerakan deteksi dini kanker payudara berbasis mamografi dalam waktu dekat. Di dalam rangka banyak kegiatan, rangkaian kegiatan di tahun ini. Ini sedang dalam persiapan, nanti diharapkan di bulan Desember kita sudah mencapai 125.000 pasien atau orang ya yang memenuhi kriteria untuk dilakukan deteksi dini. Sehingga ini merupakan gerakan pertama yang sifatnya massal untuk deteksi dini, karena selama ini nggak ada. Ya. Yang ketiga adalah diagnosis dan tata laksana. Diagnosis tata laksana ini ya sudahlah, kita selama ini kita sudah bahas banyak bagaimana menyediakan SDM di sana, bagaimana menyediakan sarana dan prasarana alat. Yang keempat adalah data atau cancer registry. Sehingga kenapa hari ini secara khusus Mr. Lesmeri dari IARC, Research for Cancer, International Agency Research for Cancer, datang khusus ke Rumah Sakit Kanker Darmais karena ada satu hal yang harus kita ketahui bersama. Ini sangat serius sekali, ya, sangat serius. Kemudian yang selanjutnya tadi udah 4, kelima tentunya pendidikan dan penelitian, research terkait dengan data. Kalau nggak ada data kita nggak bisa research. Ya, makanya Bapak Ibu semua yang sudah dilatih punya tanggung jawab besar kepada Indonesia, tidak kepada Darmais, tetapi kepada Indonesia untuk membangun layanan kanker yang kalau kita lengah kita akan selalu tertinggal dengan negara lain. Kemudian selanjutnya setelah riset ada juga rehabilitasi dan terakhir paliatif. Saya singkatkan, tetapi pada hari ini kenapa tentang cancer registry. Bapak Ibu sekalian, data Indonesia ini saat ini gagal untuk bisa masuk ke dalam CI5, yaitu cancer incidence di 5 kontinen. We are failed, Indonesia, because of lack of data. Ya. Kenapa kalau kita nggak masuk CI5? Kalau kita tidak masuk CI5, kita nggak punya data, maka artinya apa? Artinya Indonesia dianggap tidak cukup memberikan perhatian terhadap kanker. Itu aja simpelnya. Ini tentu sangat memalukan buat negara kita. Gara-gara data, ya, datanya diolah oleh IARC, kemudian kita tidak masuk kriteria, maka kita tidak masuk. Maka ini memalukan, karena data Indonesia tidak dianggap. Padahal pasien kanker kita banyak sekali. Yang kedua, bisa dianggap data kita tidak dipercaya. Dan ini tentunya hal yang di masa mendatang, karena kita sekarang sudah go internasional dan juga secara national wide kita memberikan fokus yang sangat besar kepada layanan kanker, maka ini menjadi hal yang juga kurang menggembirakan atau memalukan buat kita semua. Mengapa demikian? Karena data-data itu tidak terkumpul dengan baik dari rumah sakit-rumah sakit. Ya. Sehingga pada hari ini secara khusus Mr. Lesmeri ini memberikan perhatian karena kita nego ke IARC, gimana caranya supaya data Indonesia masih diberi kesempatan untuk bisa muncul di internasional di dalam CI5 tadi, atau Cancer Incident di 5 kontinen. Karena ini sebuah gengsi negara dipertaruhkan di sini. Bapak Ibu sekalian, tentunya Rumah Sakit Kanker Darmais sudah melakukan pelatihan 4 batch ya, di mana Bapak Ibu semua di sini, entah itu direktur utama atau direktur yang menyertai atau pesertanya ataupun yang terkait, itu sudah mengikuti pelatihan-pelatihan ini. Tahap selanjutnya adalah bagaimana mengimplementasi ini secara cepat sehingga data-data itu bisa segera terkumpul, dikolaborasikan tidak hanya di Darmais tapi oleh Kementerian Kesehatan, karena kita ada Digital Transformation Officer di sini yang akan memikirkan bagaimana caranya supaya transfer data itu menjadi lebih cepat, lebih rapi dan lebih mudah untuk kita semua. Saya kira itu Bapak Ibu, ke depan di dalam pertemuan ini akan dilakukan diskusi apa sih sebetulnya yang bisa mempercepat proses pengumpulan data ini. Ya, di samping itu kita juga nanti akan we will listen how is Mr. Lesmeri to strategy to have a strategy for collecting data for cancer, especially in Indonesia, because Mr. Lesmeri base is in Lyon, France, but I believe that Mr. Lesmeri love Indonesia so much because his wife is Indonesian. Yeah.
Yes.
So once again, welcome, Lesmeri. We need many information from you and what kind, any kind of strategy or your suggestion about improving our data collection in cancer. Terima kasih Bapak Ibu sekalian atas kehadirannya di dalam pembukaan ini. Sampaikan salam hormat saya kepada para direksi atau direktur utama Bapak Ibu yang kebetulan mungkin tidak hadir. Jadikan ini pertemuan yang sangat serius untuk dilaporkan sehingga menjadi strategi di rumah sakit Bapak Ibu sekalian dan perhatian dari direktur utama. Tentunya selain ini nanti yang bisa kita lakukan, kita akan endorse kepada Kementerian Kesehatan untuk memberikan surat lagi kepada Bapak Ibu terkait dengan timeline pengumpulan data dan lain sebagainya. Ya, Mudah-mudahan dipahami ya Bapak Ibu sekalian. Terima kasih. Mohon maaf kalau ada dalam penyampaian ini kurang berkenan di hati Bapak Ibu, tetapi kita berada pada posisi yang sangat harus lari cepat begitu. Jadi jangan menunggu-nunggu lama. Mudah-mudahan Bapak Ibu selalu dikaruniai kesehatan, tetap waspada dan semoga Tuhan melindungi kita semua. Ya, terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Thank you, Dr. Sukhowedin Ito, for your insightful speech. Next, we invite Mr. Lesmeri to provide an introduction and overview of the GICR, Global Initiative for Cancer Registry Development Collaboration. We invite Mr. Lesmeri to take the floor and share his thoughts at this time.
Thank you. Terima kasih. Hello to everyone. And I just want to start by really expressing my thanks for the very warm welcome that I received from the director, all the hospital staff here at Darmais, and Evelina and her team. It's always really humbling how warm a welcome. I don't deserve it, but it's very kind. Just to remark quickly before I get into the presentation, it's absolutely true that I love your country. I love your food a lot, which is a real problem for me because every time I visit, I have to buy new clothes because I eat too much. But maybe if we can go back one slide, just to the start. Yeah. But also just with that, I am aware of the network here in Indonesia. Evelina and her team, Diane, we've been working together, in fact, for many years at the agency and International Agency for Research on Cancer, IARC for short, which we are part of WHO, and trying to work together to really help move things in your country. And I'll speak a little bit about our activities, but before doing so, I just wanted to say to everyone a real thanks we are aware of the efforts that need to happen in each of the provinces, each of the hospitals. And really, it's that collective effort that's required. So I know many of you are on the line. I work with some of those in Yogyakarta a little closer, as well as Dr. Susanna, Dr. Dita, and her team. So I have some understanding of the efforts, and I just want to continue to encourage you. The comments were made about CI5, and it's true that in this iteration that the data wasn't accepted, but I hope that it's not seen as a negative, and instead we can use the opportunity to try to learn about some of the challenges and slowly improve those. So without more introduction on that, I did want to speak to you today a little bit about our efforts, what we call the GICR, Global Initiative for Cancer Research Development. And just to begin, we really see this as not just about data, but in fact, using data to understand the burden of cancer, understand the scale and profile, with the intention then of using it for cancer control. We're really creating policies around prevention, early detection, screening, and then also, of course, treatment, palliative care. But for all of that, we believe that one needs good data. With good data, you can make good decisions, and you can actually monitor your investments. So I'd like to just use some time this morning to share with you some of our activities, but in particular, how they relate to some opportunities perhaps here in Asia. So please, if the next slide. So I just wanted to start by sharing with you a little bit of background. Some of you may not be so familiar with IARC, but more familiar with WHO. IARC is in fact a specialized cancer agency for WHO or with WHO. We belong to WHO, but because we have a mandate with respect to science, peer review publications, research, we do also have some independence. At the agency, we were started over 50 years ago. This is our branch titled Cancer Surveillance Branch. Some of you may know Freddie Bray. He's the head, pictured in the middle. I don't have a pointer, but Freddie is familiar, I think, to some of you. And in fact, you should be very proud because our deputy head is Dr. Isabel Soramatiam, who is also Indonesian. was educated here in Jakarta and co-leads our branch. So I just wanted to say that with our branch, we have a global mandate for producing cancer incidence data. As you can see, we have 6 program areas. I'm responsible for the first, which is called Accelerating Cancer Registry Support. But connected with that, we have the indicators and then also a mandate to do research, particularly on descriptive epidemiology. And there's been mention already of CI5, Cancer Incidence 5. This actually started over 50 years ago with the beginning of the agency. Sir Richard Dahl and others tried to look at the cancer problem and understood very quickly the power of data when we can compare one country's cancer profile to another. We could learn a lot, and we could also create hypotheses about why certain countries express higher rates of one cancer versus another. Our 3 other program areas of activity at the branch are one in childhood cancer and 2 newer areas, one in economics of cancer, understanding the financial impact, not only to the patient, but the family and society. And the third is looking at social inequalities in cancer. Next slide, please. So this is just a depiction. And for me, what I like is that, in fact, our branch is trying to do things where one impacts the other. As we increase support to countries, we know that the global indicators become stronger and our ability to do research is also stronger, not only internationally, but hopefully locally within Indonesia and other places. So we tried to create a mechanism by which our main activities are actually connected to each other. Next slide, please. Or some of these made. So we've already mentioned cancer incidence in 5 continents, and perhaps some of you are less familiar with this. But in fact, this is an activity, as mentioned, began quite some time ago. We're now on the 12th or actually 12th volume of this. And what it is an invitation from registries all around the world to submit data for the purpose of evaluation. And once that data is deemed to be of a certain quality, we look at different indicators. We track incidence mortality ratio, for example, looking at stability, number of cases by year, the rate relative to other countries in the region, etc. Number of different indicators, the age-specific rate. And once it's deemed of certain quality, it's then accepted. What you can see in this depicts the evolution of this publication that's done by IARC since its first volume in 1966 to the current year. We've had a growth, you can see, from 35 populations that were initially accepted to now over 500. In this latest volume, China accounts for a tremendous amount of growth. They've launched a big program. Yes, please.
Jadi Bapak Ibu, sekedar informasi bahwa di 2013 dan 2017 kita
35%.
Cuma 35%, jadi kurang. Jadi kita kurang.
Masih bisa disusul.
Nah, ini di 2023 ini ada kesempatan lagi karena nggak setiap tahun kalau Bapak Ibu lihat. Ada 2027, 2013, 17, 2023. 2013, 2017 kita gagal. 2023 masa gagal lagi gitu. Ini kita sedang perjuangkan Bapak Ibu. Nah, disinilah kita pertemuan itu. Mohon perhatian dari Bapak Ibu sekalian. Kita lagi nego nih sama WHO. Gitu ya. Please continue.
Oh yeah, no. Sorry. So I was one of the editors, or I am one of the editors for the current volume. We did review the Indonesian data, and we were quite pleased. I think this represented the first submission by Indonesia for the publication, and we hope to work with you on addressing some of the challenges. Next slide, please. Oh, maybe it's just a graphic. Next slide, I forget. Oh, yeah. So I just wanted to also mention quickly some of the other areas, activities within cancer globally. There have been launched 3 global initiatives for cancer by the WHO. This first is around breast cancer, in which they aim to eliminate and achieve at least 60% of early diagnosis, which of course are more amenable to treatment and therefore survival. Okay, thank you. I did something here. Okay, so as you can see here, these are some of the goals, and we've created for them a framework, which of course population-based cancer registry is a main component, giving you information about the incidence and survival, and then stratified by cancer type and stage. Next slide, please.
This is target or?
These are targets from the WHO breast cancer initiative. This next one is also the WHO cervical cancer initiative, in which they've produced targets about the vaccination, number of women screened, and those who receive treatment, which of course, as we know, cervical cancer is a very preventable cancer in terms of, certainly in terms of mortality, but also in terms of incidence, but it remains a challenge for some parts of the world. So this is being addressed. Why I put these three initiatives, one is just to briefly introduce, but also to say that if we want to do work in any of these initiatives, one needs data, because otherwise, as you make investments in cervical cancer elimination, you have no basis to really determine if things have improved or not without good data. Next slide, please. And then finally, this is just a framework which we also created at IARC, again, heavily based on population-based cancer registries. These really give you the key indicators. Next slide, please. And then finally, maybe just click through. I think they're all animated, this one. If you can just, yeah. So the next area is with respect to childhood cancer. Oh, sorry, if you can go back one. There we go. Okay. So with respect to childhood cancer, we actually created within the GICR what we call Child GICR, focused specifically on childhood cancer. We have 4 implementation countries at the moment. We have an education program which has produced a series of standardized training material, and then finally some research questions that are being looked at, particularly around the diagnosis, classification of some benign brain cancer tumors, which many of you will know is a common occurrence with respect to children, almost 1-to-1 ratio with respect to malignant tumors and benign. Next slide, please. Okay, so that was a bit of background, and now with respect to the GICR, why did we create this program? Very briefly, the first issue was, of course, the need. There's an increasing cancer burden, and we know that much of this burden is in fact falling to low middle income countries where at the moment, there's not so many services available. We also know there's an inequity with respect to treatment and outcomes, but then also with respect to data. We know many countries lack the data, but also lack access to education of material. So we want to change that. And then finally, some of the opportunity is mentioned with WHO. So this all led to a movement to create some action and pull together the global partners to assist. Next slide, please. So I think much of this is known, so I won't go through it too much, but why do you need a registry? Why do you need one nationally? Why do you need one at a population level? I mean, here I've proposed some of the common questions that a registry helps to answer. Of course, what is the burden in the country? Knowing the burden, then one can act sensibly in terms of prevention programs, treatment planning, etc. We also, of course, want to know how is the burden likely to evolve, looking at projections of where to invest. And then once an investment is made, we want to, of course, monitor the outcomes and have things improved. And I just wanted to highlight that 2 complementary areas. One is with respect to the vital statistics or mortality data, but then also the population-based data in terms of incidence or new cases. Next slide, please. So I also, just before going further, we have focused our activities at the agency on one particular type of registry called the Population-Based Cancer Registry, or PBCR. This slide tries to explain to you what the rationale for that. There are other types of registries, and here I've listed the most common: hospital-based registry, pathology-based registry, and the PBCR. And you see the slide describes the characteristics of each, and then also the purpose. I don't mean in any way to say that other registries are not important. They are, but they answer different questions. If we want to answer questions with respect to cancer control planning, then it is only the population-based registry. And the reason for that is that we know the denominator. We have a defined target population. If, for example, if you took Jakarta, you could take the 5 districts: central, north, south, east, west, Jakarta, all the residents in that population. One would wish to track the occurrence of new cases or incidents and be able to then, and the example I've given here often is a child coming to you and saying they did well on a test, they scored 7. Correct. It's useless if you don't know what the test is out of. If the test was out of 7, it's a very good score. If it's out of 100, it's not so good score. So that's the difference. In a hospital-based registry, you do not know the denominator, and similarly with pathology-based. Next slide, please. So this just gives you a definition of a population-based cancer registry. It's a systematic, ongoing collection, analysis, management, dissemination of data in a defined population. And from that, the main key indicator, of course, is cancer incidence. And it's the only registry by which one can produce rates. The other ones, hospital-based registry, one should only be looking at the rank of cancer, the number of cases, but not the rates, because you do not know the denominator. Next slide, please. So this is just, again, a little framework we've developed, and we published this some time ago. It's available in the literature. But again, simply to say that when you look at the continuum of cancer control, moving from a healthy patient, unfortunately, to one who's been diagnosed, living with cancer, through to perhaps dying with cancer, the registry actually gives you the base information from which to inform yourself about cancer control, both with respect to incidence and survival. And it really is only the population-based registry from which this can come. You have complementary surveillance systems such as surveys, vital statistics, as already mentioned, but the main one is from PBCR. Next slide, please. So this is just to say that while we collect data, as you are doing in your country, it's also important to think of the activity with respect to cancer control, and in particular, use of the data, to be able to use the data to understand its meaning, and also to be able to work with those, such as the director and others running hospitals, to be able to help with the planning and providing information to them, so that it's not just seen as an activity of data collection, but in fact, it needs to extend into the realm of data use and action. Next slide, please. So with respect to the GICR, what is this then? Several years ago, about 10 years ago, at the agency, we brought together different groups who have been working, and you see some of those depicted on the right-hand side. International Atomic Energy Agency, the USNCI, PAHO, WHO, UICC. These were all global actors, if you will, helping countries, but the issue was that it was quite uncoordinated. Groups were coming to country, trying to help, but now through the GICR, what we've done is try to put the coordination together so we can have bigger impact. So over the last several years, we built the foundation, moved to implementation, and now we're in a full phase of being able to extend the support around the world. Next slide, please. I won't go through this in much detail, but just to simply say the goal of this is really to use the data to save life. It's not to create an incidents report or publish a journal article only. It's to go beyond, and you see some of the outcomes divided into long-term, short, medium. Next slide, please. Also, we stratified this in terms of focus. We have one focus looking at global coordination, one at the regional, and I'll explain a little bit for Asia. And then, of course, all of it is directed towards the country. As the director mentioned at the beginning, the efforts are really about trying to work with countries to improve your data, improve the use of the data, and ultimately lead to better health outcomes for residents of Indonesia and other countries around the world. Next slide, please. So the way we've structured this, I'll show, is we have 6 what we call IARC GICR hubs positioned around the world, trying to do the work that we've done in Lyon, but now bring it out to the regions and make it more accessible. And on the right-hand side are the core functions. We're trying to build capacity. So the first is training. Evelina and her group have been quite involved in the number of courses we've been running in the region. Dita, as I mentioned, from Yogyakarta, was recently at the agency as part of our IARC summer school, and we try to provide more and more opportunities. We're trying to help between courses with registries, problems you may encounter. Of course, encouraging research towards cancer control, and then ultimately networks. Next slide, please. So this is just our IARC hubs. We cover the regions depicted here and in the non-gray. So the first hub is with respect to Latin America, and it's based in Argentina, in Buenos Aires. We also have a hub for the Caribbean region based in Trinidad, Tobago. And then we cover all of Asia, Africa, all of Asia, and then finally the Pacific Islands. So the hubs are those in yellow. So one in Buenos Aires, as mentioned, Trinidad, Tobago. Here in Sub-Saharan Africa, we have a virtual hub based at Oxford University. And Izmir, Turkey covers Northern Africa, Western Asia. And then the Tata Memorial Center in India, we have again for Asia. And then finally in Fiji for Pacific Islands. Next slide, please. I just wanted to highlight specifically for Southeast Asia, we have the Tata Memorial as mentioned, but we've also constructed collaborating centers. So these are agencies that are working with IARC, working with Tata to help deliver support. So we have one at the National Cancer Institute in China, in Beijing, similarly in Thailand, in Bangkok, in Korea, in Seoul, and then finally in Tokyo. So now we have 5 institutions that are working together with IARC to help countries in the region. Next slide, please. So this is just an example of the group in Korea. These were days where I wasn't so chubby as I am now, but we were in Korea, and they launched IARC GICR Summer School, which we hope to replicate across the 6 regions, trying to make opportunities available for training. And for some of you, you may be interested, they've also launched master's program in cancer, global cancer registration and cancer control at the university in Korea, and also looking at PhD programs. So this is some forthcoming opportunities available. Next slide, please. This is just a summary of what was shown on the map. So we have the hub region, the naming or where it's located, and then the associated collaborating centers. So in summary, the program is quite large. We're trying to address about 85% of the world population, which is roughly 150 countries or so. We're doing this through structures of IARC hubs, for which we have 6, and then also associated collaborating centers. And the idea is to share standardized teaching material and offer support more readily and more intensely to countries. Next slide, please. So the way we work, this just depicts the model in which we use. I won't go through this in great detail, but simply to say it begins with a country assessment by which we try to work with the country to identify some of the issues. I've been fortunate enough to visit your country several times, which is what we call the site visits, offering some specific recommendations on what we feel might be some activities the country would wish to undertake to improve their cancer registration. If there is sufficient interest and agreement, we can advance this to a formal level of support by which IARC signs an agreement with the country to work on joint issues, and then finally to try to strengthen evidence. Next slide, please. So I just want to end with a few highlights of what we're doing, particularly in this year. The first has been a program, what we call GICRNet, which is, if we imagine CanReg 5, CanReg 5 is a software we make available and has been used here also in Indonesia. But the trouble with CanReg 5, historically, we had the developer at the agency. He's only one person trying to answer all the questions from around the world. It's just not feasible. So we realized we had to create a network, and we wanted to put the network in each region. So we have now a series of trainers on CanReg 5 who have standardized material and who can help. This is what we call the GICRNet. We also soon will be available to all of you freely is a set of education training modules that you can access online. Maybe related to the electronic health, we have an investment in DHIS2. So for those not familiar, DHIS2 is a widely used health information system from around the world, particularly in Asia, but also in Africa. And what this represents now is the first opportunity where a country using DHIS2 does not have to enter the data twice. It can be entered in DHIS2 and transferred directly to the registry. So we're working on this. There's a pilot project, and we hope to make this available at the end of the year. We've replicated the cancer module. We built the first cancer module in DHIS2, but it entirely holds all the business rules, all the edits of CanReg. And then finally, we try to increase some support by what we call partner countries. Next slide, please. I think this just then highlights some of what I said. I really like this slide because this is one of our networks trying to depict the geographical spread. One thing we insisted on is that we wanted people from the regions. We did not want to have solutions coming from Europe, coming from North America, but directly from Asia, directly from Africa, Latin America, Caribbean. And so this is what you see. In fact, some of the trainers for Asia will be here. Aziza, from some of you may know, from Malaysia, also from Japan, Thailand. Let me see. Yes, and from India, and Rongju from China. So in fact, we have 4 trainers. This is one on just looking at data quality. And next slide, please. Yeah, this I've already mentioned, trying to create standardized material and helping. Next slide, please. So this is a summary of what since we created this activity, we've had now 5 networks, starting in CanReg, also coding, staging, data quality analysis, and most recently child cancer. So what you have available now are about 100 resources, 100 different people that can help with issues on these topics. Next slide, please. So I also just wanted to highlight, this could be of interest to many of you. Coming in September, well, maybe more realistically, I should say October, we will be releasing a set of 15 modules. So these will be self-paced, meaning you can log on, start a module. Maybe you only have half an hour, you stop, you can come back to the same point and continue. And they translate all our basic training that we've been doing at the agency. So they'll be available in 3 languages, initially English, French, and Spanish, and then hopefully through time. I think this is quite exciting, and Evelina knows Dr. Max Parkin and many of the others. Really, some will say sort of the father of cancer registration. He's been heavily involved in this activity and transferring all his knowledge to this. Next slide, please. So I talked already about DHIS2. I won't repeat, but simply to say, if you wish for more information, we do have a program sheet that describes this in more detail. But the idea is by December of this year, we will make the module available. Next slide, please. And this was the partner countries. And here, what we're trying to do is identify countries in the world that have an interest in cancer registration and duly are ready to invest. And with that, from the agency point of view, we will try to intensify the support and try to advance and take advantage of the opportunity. Next slide, please. I think this is near the end. I just wanted to very briefly mention, we're in the process of intensifying some of the focus, in particular with WHO, under 3 areas. The first is with respect to implementation and the WHO cancer initiatives. Also to look at a GICR net course on policy, data to policy, and then finally the DHIS2, which I mentioned. Next slide, please. I think that's the final one. Yes. So I'll stop there. Sorry to take so long. Sometimes I can get too excited about one slide or the other, but hopefully to share with you a little bit of the work. And then the next coming this afternoon and tomorrow, I'll be discussing with Evelina and her team about some ideas specifically for Indonesia. So thank you very much for the time, attention. Happy to take questions, but my email is also there for those who wish to follow up by writing. Thank you so much.
Thank you to Mr. Lesmeri for the informative presentation. We still have one presenter left. Now we would like to invite Evelina Susana MD as the Head of National Quality Control for Cancer Burden Data and Cancer Network Department to share updates regarding the Indonesia Cancer Registry. To Evelina Susana MD, the floor is yours.
Terima kasih untuk please allow me speak in Bahasa, but the presentation in English.
No problem.
So you will get used to it Bahasa. Ya, ini saya akan mencoba mempresentasikan apa yang harus kita lakukan dalam salah satu kegiatan. Jadi yang saya hormati Bapak Direktur Rumah Sakit Kanker Darmais beserta jajaran, terima kasih sudah hadir dan memberi dukungan penuh kepada kami selaku penggiat kegiatan registrasi kanker dalam hal perubahan atau transformasi kesehatan di Indonesia. Tentu kita di sini saya mengatakan giant step in development of population-based cancer registry, since all of the resource now the government put to support Indonesia has the good quality according to the standard of CI5, quality of data, supporting by DTO to have the system, the new system, networking system, and also the standard system in collecting data. Selanjutnya, ya, Indonesia, this is very huge country ya. Kita punya 275 population and 300 ethnic and 1,340 sub-ethnic. This is really a huge country, and we have 733 local languages, but we have Bahasa Indonesia as the national language and living in 17,000 islands. And kita punya sudah 16 pusat untuk data kanker di Indonesia yang sudah kita bangun bersama-sama sejak tahun 2015, yang kita belajar dari Kota Jakarta di tahun 2006 yang didukung oleh PTN dan Pelayanan Kesehatan Rujukan Kementerian Kesehatan. That of course we already trained around close to 1,000 staff for the cancer registry. We have a registrar, however, most of them working as a part-time. Doesn't have something fully work and then have the career in those kind. This is still our challenge. Lanjut. Ya, kita masuk ke transformasi kesehatan yang sudah kita jalani selama kurang lebih 2 tahun. Lanjut. Ini as the background of us, 70% of the cancer cases coming with the very late stage. Meanwhile, we have to achieve 60% of the breast cancer in early stage. Jadi di sini tentu kita akan berusaha mengejar yang keempat ini. Yang keempat di sebelah kiri, akses diperdekat, kemudian kualitas untuk pelayanan juga baik, waktu tunggunya menjadi lebih pendek, kemudian tersebarnya dokter spesialis merata di tanah air. Lanjut. Ini ada 6 pillars our transformation. Yang lain, yang terutama di sini, we trying to have a support from the number 6, technology information transformation health, digitalized system. Of course, we would like to have a very easy or what do you call it now, the era of percepatan itu agile, something like very quick communication with them. Lanjut. Of course, we would like to have something like changing paradigm. We hope not one day, then the close future we have the breast cancer relation, early stage cases, something like that. So that's why gradually referral system we will put in the stratification. Something for the district and city, we will have unit cancer care or comprehensive cancer care in province, and then comprehensive cancer center, vertical hospital from Ministry of Health in 15 provinces out of 34 provinces in the country. More or less the same like US. US has the 50 countries, and then they have 25 comprehensive cancer center, include the very famous one, MD Anderson, and then National Cancer Institute. So we would like to try Dalmais as National Cancer Institute one day.
Yes.
Yeah. Next. Ini dia. This is the Rumah Sakit Madya. It means we will have the unit cancer care in the city and then in the district. And then comprehensive cancer care, it means in vertical in government, local government hospital, like government hospital, and then Rumah Sakit Paripurna, it means the comprehensive cancer center in the country. We have around 15. Lanjut. Here is the target we have to achieve in 2027. All of the city and district 514 will have the hospital cancer care. So from this area that we will try to have all of the data put in Satu Sehat Indonesia. Then cancer registration, Central Cancer Registry in Darmais Cancer Center will have the access, have the portal, supporting by Digital Transformation Office, to have all of the data collection according to the variable we need for the support of the quality data. Lanjut. This is the regionalization according to the Comprehensive Cancer Center, including all of the Sarjito. Sarjito will support North Borneo, North Kalimantan, number 4. That's supporting by, should covered by Sarjito. Besides, they will cover all of the Yogyakarta. So they have 2. Then for the Cipto Mangunkusumo has 4 regionals area. And then for the Fatmawati in Jakarta will support Papua, something like that. All of the country will support by comprehensive cancer center. And then of course Dharma is a national cancer center, then it will become a national cancer institute. Here's the 7th program that we will conduct. Then of course for the comprehensive cancer management program like National Cancer Control Program that we will announce, Ministry of Health working together for all of the system in the country, including Ministry of Education for support curriculum, and then Ministry of Finance, Internal Affairs or Home Affairs, since now we have a decentralized government. All the governors have their own budget for comprehensive cancer center in the province. And of course, with the NGO society, all of the system in the country will join together, working to put the cancer as one of the top priority in the country. Lanjut. This is the preventive and the promotion. Lanjut aja, that's our director already mentioned. And then this is the screening. Since we have the top 3 for the cervical cancer, follow the 70, 90, 70, 90. And then also for the breast cancer. And for the lung cancer, we try to have the low dosity, because this is the first rank in the men, and then the 5th or the 6th rank in the female, because of the passive smoker also.
Sorry, I think organized screening programs are opportunistic.
Now the government will put at the national level also, including for the vaccination. We not only girls, but also boys. Boys and girls. And then for the screening program for the HPV, HPV testing, what call it, something like double with the, if not infection acetic acid, or follow with pap smear if the high risk of the HPV will detect. And then for the breast cancer, like mentioned, then we will have something like mammography, the whole nationwide, they will put the mammography.
It's organized in the sense that women are, in the case of breast cancer, cervical, they're asked to come in,
yeah,
followed up, or is it opportunistic where they have a service?
They will have service from primary health care. Now the government put ultrasound. Following breast self-examination, and then if there's something lesion, they will send to the hospital cancer care to have the mammography. And this is all of the system will, this is, we call it the transformation healthcare in Indonesia. So the government will cover all of this with the National Health Insurance, BPJS. And then all of the data will go to the Satu Data Indonesia, Satu Sehat Indonesia, One Health. Satu Sehat we call it because this is the name from the since the era of the COVID, Ministry of Health. Lanjut. Yeah, of course with the diagnosis and therapy, we work in the multidiscipline team. Lanjut aja. And this is the palliative care. Of course, the first program of palliative is pain control management. We trying to put the opioid as the first priority of us to get the access for the opioid. Lanjut. Medical rehabilitation and supportive therapy. Terus, of course, for the education and research, that's including the training for the cancer registration. Lanjut. And this is for our working. Of course, you already know about our result. Lanjut. Yeah, this is for the Mumbai. We something update our knowledge in Mumbai, and then also working together. Next slide, with the Thailand for the gears collaborating. We joined the ASEAN Cancer Registry Forum. Lanjut.
Yes. And
here is we trying to have the data 2013, 2017, because we only have this is the estimation according to the global burden of cancer. Okay. Then we try to have the collecting the rest of the 2013-17 to the 2018-2022. We were working for this period. So after we will collect all of in this year, we hope that we will have the good quality according to the CI5 standard. Then we will report. Then I asked Freddy at the time to have a chance to look our data. Then we try to have the 1.9 million incidents.
As you can see, some of the main indicator observers expected.
Yeah.
It's still sort of in the range of 20-25%. So
Yeah.
there's some underreporting.
Yeah, so that's why we times 5. So that's why we will hope we will have the 1.9. Then the mortality 1.1. And this is we try to reach the data.
Sure.
Yeah. And we hope. Lanjut. Yeah, this is the strategy, the real national cancer. Bridging data to the whole hospital, they will have the direct access. Then we have the same, what we call it, the system, IT system. The Dharmais IT will lead them to put the something like you mentioned. So that's why we would like to put our 1-2 staff from the IT will join if have a chance for the learning for the electronic system. Because we now the bridging data close to the 300 hospitals in the country already have a booking data to the MICE. And then of course access to Satu Sehat, it means this is all of the report from the National Health Insurance that cover around 80% of the population. It goes to the data. So that's why we will have a portal from the data office, digital transformation office in Kunjungan. From data portal, of course, we will trying to put the capacity building for the cancer registry workshop. We already have the 4 bus in this month through all of the level of the cancer service in the country. So that's why they will send the data following the quality data of the CI5. For instance, for the definition of the date of incidents, we have to have the same.
Yes.
And of course, this is very important for us. When people say cancer or not cancer, according to the incident date.
Yes.
Yeah, this is we
Some
have
of
the
it
same.
you may want to consider putting in what they call a standard operating procedure.
Yeah.
Which is documenting really the practices
Yeah.
that you're hoping everybody follows to make it systematic.
System. Yeah, we put everything in our website actually. So that's why they can take all of the information or the curriculum or definition operational from the website.
Very good.
Yeah. Lanjut. I think that's all of the system that we have. Yeah, this is the Satu Sehat platform. Because in Satu Sehat, all of the data including stroke, heart disease, diabetes, but we have the ICD-10, and from those kind of the coding, we will retrieve all of the data and then working together with people in the hospital, trying to have the ICDO coding for them. We will something like after we compile, we communicate with them in the district office. Lanjut. Yeah, this is the system that we will. All of the National Health Insurance, BPJS, bridging data, cancer registry, healthcare facility, and then also the Ministry of Health support us to have the data from clinic, laboratory, pharmacy, and everything, and then also from the society, because some of them have the data also, and then Cancer Foundation. Of course, with the survivor group in Indonesia, we have one Cancer Information Support Center. They also help us for the follow-up of the cases. Then, of course, we will go through the IL and the Ministry of Health. Then we will put in the dashboard of the National Cancer Center. Lanjut. Yeah, this is the system that built by DTO to help us to put the data in the system. That's our trying to achieve submission in 2026, but we trying to have 2013, 2017 trying. We trying to reach the rest of the cases that we left. So that's why This is we will put as the standard to go to the 18 and 2022 of the cases. Lanjut. Yeah, this is data entry. The registry we will data processing here, and of course we will work with the 15 comprehensive cancer center in the country. Then with all of them will something like adjust the data from the 514 hospital cancer care. Of course, we're working together with the provincial district office and health office for the follow-up, because they have a reporting of the mortality, and then of course with the primary healthcare, because from the primary healthcare we will have the real incident date of the cases, because the BPJS National Health Insurance will have the referral cases from them. If they would like to have a support of financial, they should have paper from primary healthcare. So that's why from primary healthcare, we will have the real incident date of the cases.
So you
Because
collect it
suspect-
from the primary health center or from the cancer centers?
Cancer center, this is the hospital belongs to the government,
Yes.
local government.
Level 3 years.
The first level in the provinces.
The primary health.
Then goes to the hospital unit, it means in the district or in the city.
Township.
514. And then under them, they will working like in Jakarta. For instance, we have 5 local government hospital, but they will work together with 460 primary healthcare, divided into the 5 regions in the Jakarta only. So that's why this is will collect together in Cipto Mangunkusumo, because Cipto Mangunkusumo, that's vertical from Ministry of Health. So that's why they will cover all Jakarta, cover West Borneo, Banten, and then also Lampung. The 4, this is will under guidance of Cipto Mangunkusumo. They will working from the comprehensive cancer center in Cipto Mangunkusumo, comprehensive cancer care in Jakarta. That's they have 4 comprehensive cancer care like apa namanya itu Pasar Rebo,
With Stewart.
Pasar Rebo Hospital, Rabu terus tuh Cengkareng, and then Pasar Minggu, kan yang satu lagi Koja. That belong to the governor of Jakarta.
Okay.
So they will working together with Cipto Mangunkusumo. Cipto Mangunkusumo will have the regional Jakarta Cancer Registry population
Because
base.
we believe that Jakarta is the most highest population in Indonesia. So when we gather the data in Jakarta, it will be represent also.
Yeah, of course.
Indonesia.
Yeah, it's about 20 million.
Yes.
Yeah, so this is from here. But also then all something like Yogyakarta will guide the north of the Kalimantan, not Tarakan. It's the one Kaltara, we call it. That's one of the area in Borneo, close to the Kuching, close to the Sarawak.
Okay.
That's the neighbor. So that's why we would like to know how the figure of the cancer, is it more or less the same with the Kuching Sarawak from Indonesia side? Yeah, this is guided by the Sarjito. Lanjut. Yeah, this is the what do you call it, the categorized of the variable. Then in you see that we have the 1.6 million data. It turned out around 2% only the real data. There's so many duplicate, because they will follow the system, the referral system. Something goes to the first from this hospital, go to this. So that's why we will have something like 4 times of one cases. But since they have the unique identification, so we know.
But in fact, high quality registries, one of the indicators we usually look at is number of notifications of cancer for a patient.
Yeah,
And you're usually hoping it's about 2 at least, because in a well-functioning system, you should have maybe the patient presents
Yeah.
at a hospital,
Yeah.
and then maybe the pathology report, so
so
at
all
least
of them
2.
we have.
So
yeah.
this is not a bad thing, I think, and you have to do record consolidation to bring the information together. So
We have the unique ID.
Yeah, that helps.
so,
Then you
so
can
that's
do
why we know the
deterministic record linkage
Yeah.
instead of probabilistic.
Lanjut.
How widely used is the ID now? Is it
Oh,
throughout the whole country?
Yes, the ID. Oh, kenapa? Coba
Condition.
Yeah, of course.
Condition.
Yeah, that's the condition code. Itulah
Condition
dia.
code.
Ya, itulah dia khusus. Kita tarik dari situ dan kita langsung change jadi ICDO. Itu lebih dekat di situ. Ya, ya. That's the. This is the new building.
Yeah, it's the women and cancer, child, yeah. Very nice. Thank you.
Technique edit.
Lots of work with that, yeah.
Yeah.
I'm sure. When will it
Terima
be?
kasih untuk semuanya. Mungkin ada 1-2 pertanyaan dari silakan.
Thank you, Evelina Susana MD, for your enlightening presentation. The next segment of our event is a question and answer session on the collaboration of core cancer registry development. For the first phase, we will allow 2 participants to ask questions. Pada Bapak Ibu sekalian yang ada di Zoom, saat ini kita akan memasuki ke terakhir, yaitu tanya jawab. Mungkin apabila ada Bapak atau Ibu dari peserta yang hadir dalam Zoom pada siang hari ini, jika ada pertanyaan boleh mengklik raise hand ya. Nanti akan kami tunjuk 2 penanya terlebih dahulu. Kita masih punya waktu sekitar 30 menit. Ya.
Nanti diterjemahkan kalau bahasa
Indonesia boleh.
Tanya dalam bahasa Indonesia,
boleh.
bantu tanyakan dan juga akan kami translate ke bahasa Inggris dan juga sebaliknya. Silakan Bapak Ibu, mungkin ada yang ingin bertanya atau berdiskusi bersama.
Iya. Ada nggak yang di chat itu ada tuh? Apa tuh yang di chat kalau orang? Coba di kolom chat. Apakah dia berfungsi? Oh, friends. Oke. Ada mesin. Kalau ada biar kita. Kalau udah selesai, kita langsung diskusi. Kalau nggak ada pertanyaan, apa lagi makan?
While we wait for participants preparing the question, may I borrow your presentation? I have a question. Coba dibuka slide lagi yang tadi peta tadi.
Bawah.
Asia.
Ya, bawah.
Yang ada bintang-bintangnya tadi.
Ya. Yang hub-hub itu tadi. Nah,
bawahnya lagi.
kita punya. Nah,
so regarding this area,
Yes.
you can see that your base, one of your, what do you call this?
We call it collaborating centers.
Collaboration center is in Bangkok.
Yes.
Bangkok, I think Bangkok, Thailand is very small space comparing with Indonesia.
Yes. Yeah.
Why don't you put this one?
Yeah.
That's first question.
Yes.
The second question is comparing with other country with have the same situation like Malaysia, Thailand, Philippines. Which one is the best country who already passed the test, quote unquote? So when they pass, what is the strategy of this country? So we can copy or we can learn from this country.
Sure. Well, thank you for the question. With respect to the first one, why the selection of these? we get that a lot. Basically, what we try to do is look at places in the region that have historically and for some long period had high quality registries. And we approach them with the simple request, can they share their knowledge?
Okay, so it means Bangkok or Thailand
Yeah,
have the best
not necessarily the best, but they have high quality cancer
cancer
registries.
registry.
Yeah, similarly with China, Korea, and Japan, and of course Mumbai. Your question about the neighboring countries, sort of adjacent to Indonesia, like Malaysia, Thailand, Philippines. It's varied, would be the short answer. Thailand has a number of high quality registries. They've had them, for example, in the north in Lompang, Chiang Mai, Khon Kaen, Bangkok, and then in the south, which I always forget, starts with an S. Similarly, in Malaysia, a long-standing registry of high quality has been found in Penang. While in the Philippines, you have Manila, but then also Rizal, which is sort of one area. They in the past times they also had Cebu, Davao, but some of those have been up and down, meaning sometimes they've been lower quality because some change in the staff. So in terms of how they've overcome, for me, if I could offer just some general comments, I think one really is political will. I think it's hard to have a good cancer registry without the support of very senior individuals at the Ministry of Health and within hospitals. I think that's very important. The second really is, I think, to really assign a dedicated leader, somebody who is in charge of the registry in a particular region, has the ability to make decisions and is given support. Another area we find, of course, is the necessity for retention of staff. Because one common problem is staff can perhaps be hired initially, but then there's no budget in year 2 or year 3. They have to move, and then when the budget comes back, you have to find new staff, and you start again. You have to train them, have them. And I think cancer registration is such a practice where it takes several years before the person is really, really knowledgeable about the area. The other area we found that has been an important component towards success has been the involvement of clinicians and support for clinicians, but perhaps being careful about them entering the data. We've seen some models where the idea is the clinician actually enters the data, but to be honest with you, around the world, there's almost no example where that works. Because the clinician is quite busy. So rather than a passive system, we advocate one with more active, meaning the registrars are trained, they look through the medical records, can pull out the information they need. If they have questions, they can approach the physician, but not to rely on the physician, because most cases, the physician is too busy delivering care. They cannot take the time to complete the cancer registry. And then the final comment, if I could offer, might be around being very purposeful and realistic about the funding you have. I know that the desire currently in Indonesia is to cover the entire country. And I give this very simplistic comment to illustrate the point. If a cook is supplied with enough flour to bake two pie, but you ask them to bake 30, you will have 30 poor quality desserts instead of 2 good quality. So one piece you may want to consider is sort of a phased approach, where yes, your goal ultimately is to have the whole country, but you start with 1 or 2 regions, 1 or 2 population where you really invest, have good quality, because from there you can then get a picture of cancer reliable that you can then start to maybe extrapolate to the country and slowly grow, rather than trying to do one of the publications I'm working on at the moment that will be hopefully in the literature is sort of a roadmap for registries. So stratified by phase. So initial phase of I have no data now and I'm planning a registry. what are some milestones, considerations that I need to achieve. And then secondly, I start my registry and we call that the initial phase, the first 3 years. What are things that a registry should do that are very critical? And then finally, last 2 phases, which is maintenance, divided by low quality, high quality. If I have a registry that has been operating for many years, but still low quality in terms of reliability, complete coverage, what are some steps I need to focus on? And then finally, high quality. So I'm working on this publication. I can share it with Evelina to share with Olivia once it's.
One more question. I have heard that some colleagues mentioned about the cancer registry is complicated, more complicated. So, is there any innovation with WS5 simple or facing culture, the culture of this, the culture of the management system? You mentioned about the changing of the data stuff.
Yes. Yeah. I mean, I think that's one avenue why again we emphasize population-based registry, because actually it is more straightforward. There's only maybe about 10 to 14 data elements that you need for international. And even among those, the core ones for producing incident survival are quite few. It's maybe only about 10 data items. Whereas a hospital-based registry is much more involved, much more complicated, because they could look at things like comorbidity, relapse, chemo agents, surgical, radiation dose. We don't ask for that internationally, because we know that the more you ask, the quality decreases. So that's what we've tried to do in our software on CanReg 5, made available free to try to simplify the process.
Coba kembali ke ini Zoom-nya. Ada yang bertanya?
You mentioned that the ARC is interoperable with HIS. What actually the framework that you, because in Indonesia in Sehat we use FHIR, and for the terminology for the diagnosis we use ICD-10 and ICD-9 for the procedure. I mean, like if that line is by collaborating and
That's true. So most definitely we can collaborate. I can share with you details, technical details in the DHIS2. But simply to answer your question, what we did in DHIS2 is create a cancer module that replicates the fields of the cancer registry. So we collect from ICD-03 to morphology, date of incidence, date of diagnosis, all of those fields, as you would in a normal functional cancer registry. And we also build business rules, for example, that make sure when a person enters a diagnosis, that it's compatible with other variables. For example, you don't have prostate cancer appearing with female. So, and in terms of the linkage, we built an API. So an API will transfer the data from DHIS2 directly to CanReg. But we can share, later in the year, we will have a webinar where we describe the API, how it's used, the setup of the DHIS2. There'll be build the software, like an installation package that you can download with some help support.
Jadi gede.
But we're happy if you have specific questions. I'm not the technical person working on it, but I can connect you to those who are.
So in general, the variables and the terminology is already mapped in
Exactly.
fire and the
It was
ICD
built,
outbreak.
yes, it was built, yeah. And then we use the reporting, for reporting, we use ICD-10 because it groups by site. But for actual data collection, it's ICD-03.
Just mean that DGS has took its data network for the speaking
Exactly.
and goes down to the company.
That's right, yeah, so API, yeah.
The GSIS is not the system that implemented in the directly in the hospital, but it's the kind of bridging.
No, in fact, HS2 is used in the hospital. Where it was first used was reporting to ministries at an aggregate level. Ministries wanted to know, for example, at the end of the month, how many cases of infectious disease, how many cancer, how many diabetes. Reporting, they call it more of an aggregate level, but then DHS2 evolved what they call tracker, which is individual data. And that's what we built the modular. So it will sit in DHS, and DHS2 is available free. There's no cost to open and
I will try to menyapa mereka di bahasa Inggris.
Say hello.
I want to say hello. Bapak Ibu sekalian, saya mau coba bertanya nih kepada salah satu nih yang ada di sini kelihatan dari RSUD Al Ihsan, Provinsi Jawa Timur ya kalau nggak salah. Jawa Barat, Jawa Barat. Bentar dulu yang protes dari sana biar melek. Halo, Jawa Barat, Al Ihsan. Di sana ada siapa ya yang ikut? Bisa nggak cerita situasi di sana kira-kira seperti apa? Saya nanti juga mau tanya yang di Kalimantan, yang di Sulawesi misalnya gitu. Hambatannya apa? Mumpung nih ada Les Mary di sini. Silakan Bapak Ibu. Saya sekalian pengen dengar suaranya gitu loh.
Siap. Di sini saya izin, mohon maaf ini yang diceritakan tentang apa ya?
Ya, jadi di sini cerita, iya. Ini kan kita sedang bicara tentang cancer registry ya Bu ya. Nah, saya pengen tahu di Al Ihsan itu cancer registry-nya situasinya seperti apa kendalanya begitu, sehingga kita bisa tahu.
Izin, sebetulnya saya di sini sebagai kepala ruangan rawat inap kanker center, Pak. Kalau untuk registrasi kanker itu ada di bawah rekam medis. Kebetulan izin bagian rekam medisnya belum baru keluar, lagi keluar gitu. Nanti saya panggil dulu untuk bisa cerita lebih baik lagi, biar nanti kalau sudah ada kita akan informasikan seperti apa untuk
Ada isu nggak Bu di situ? Misalnya cancer registry susah atau misalnya lancar-lancar aja gitu? Terus butuh apa? Nggak tahu ya, belum bisa ya?
Belum bisa jawab. Saya hubungi dulu.
Oke. Baik, terima kasih ya Bu ya. Ya, terima kasih ya. Terus saya coba lari sekarang ke Malang nih, ada RSSA Saiful Anwar.
Ya, kemarin udah kesini tuh. Kemarin kan udah kesini kan, kunjungan. Malang.
Ada Saiful Anwar. Selamat siang Bu. Bisa nggak Bu cerita di Saiful Anwar kira-kira kayak gimana sih proses cancer registry-nya, apa kendalanya, kemudian butuh apa sih sebetulnya supaya bisa jalan? Silakan Bu Putri ya.
Thank you for the great explanation from the speakers today. Hari ini saya mendapatkan beberapa informasi yang cukup banyak dari Dr. Evel, sekaligus juga narasumber dari AYAK. Mungkin kalau dari Saiful Anwar sendiri sangat amat masih baru sekali untuk memulai, karena kami baru saja memulai untuk pembuatan SK untuk tim registrasi kanker di bawah tim onkologi dari rumah sakit. Tapi kemarin pada saat kami rapat dari beberapa SMF itu kebetulan sudah ada yang punya datanya. Jadi insya Allah nanti ya kita akan lebih mudah untuk menyatukan data dari beberapa SMF seperti dari urologi dan patologi klinik itu mereka sudah punya data. Mungkin itu yang baru kami lakukan di sini. Jadi baru inisiasi yang awal, tapi harapannya adalah dalam beberapa bulan ini nanti ketika SK sudah ada, maka kita akan percepat untuk melakukan registrasi kanker di Saiful Anwar. Mungkin
Ibu, terima kasih Bu Putri ya. Jadi ke depan kalau misalnya ada perkembangan apa, boleh kita sharing-sharing sama kita gitu. Jadi kita tahu perkembangannya di daerah seperti apa gitu ya.
Iya. Terima kasih.
Terima kasih Bu Berlian. Kita mau tahu untuk apa namanya ya? Apakah nanti registrasi kankernya itu ibaratnya itu mandiri atau kerjanya itu bagian apa namanya itu ya, part time ya, jadi apakah nanti dia full time ya, jadi orang yang bekerja di registrasi kanker punya karir atau dia itu jadinya hanya bekerja part time aja?
Iya dokter, sampai saat ini memang tenaga yang kami ambil dari untuk pengisian datanya nanti masih part time, tapi ya harapannya kalau melihat dari presentasi hari ini sih memang untuk idealnya adalah harus yang full time ya dokter. Iya. Iya, mungkin dari masukan hari ini adalah untuk saya pribadi adalah untuk mengusulkan kepada direksi seandainya bisa adalah kita membutuhkan seorang petugas registrarnya yang full time. Terima kasih banyak dokter masukannya.
Ya, supaya membantu klinisnya nanti. Dari Malang udah pernah ada yang dikirim latihan nggak ya kemarin? Karena kita udah buka 4 periode.
Dari Malang sudah, kebetulan saya sendiri sebagai verifikator. Iya.
Baik, terima kasih. Nanti kita tunggu untuk kelanjutan perkembangan registrasi kankernya.
Siap, terima kasih banyak.
Terima kasih Bu Putri. Saya mau beralih ke Kalimantan. Ada nggak Kalimantan? Coba lihat.
Oh, oke.
Coba dibuka.
Ada tuh Kalimantan.
Kalimantan ada Doris Silvanus tuh ya.
Tuh Kalimantan Tengah. Kalimantan Tengah.
Dari Doris Silvanus.
Ada tadi itu Kalimantan Tengah. Tuh, nah, tuh Doris.
Hey, siapa nih namanya Mbak?
Nama saya Ibu ini Pak.
Oh Bu, ini sama Bu sama yang lain. Saya pengen tahu kondisi di sana seperti apa Bu, cancer registrinya.
Untuk kondisi sekarang ini Pak, untuk proses registrasi kanker ini memang kami baru memulai. Kemudian untuk memulainya itu kami kesulitan karena untuk sekarang ini memang masih part time. Jadi kami juga masih transfer informasi kepada teman kami untuk menambah tenaga untuk sekarang ini supaya ada tambahan tenaga gitu Pak. Karena memang untuk pengisiannya itu banyak banget ilmu yang harus dipahami dari riwayatnya, kemudian dari penentuan klinisnya seperti itu Pak. Jadi kami masih banyak belajar terkait registrasi ini Pak. Jadi untuk tahap ini kami masih belum kami masukkan ke rantrek 5-nya Pak. Mungkin itu.
Ya, baik. Makasih ya. Ya. Kalau bulan depan saya minta datanya gitu sudah bisa keluar berapa?
Kalau untuk sekarang ini Pak masih baru 10-an Pak, itu juga masih belum divalidasi, masih belum dalam registrar. Ya.
Terima kasih ya Bu ini ya. Al Ihsan lagi raise hand, tapi saya mau ke ini dulu ya, Sulawesi dulu ya. Makasih ya. Nanti habis itu baru Al Ihsan ya. Mana? Sulawesi mana? Coba buka. Hah? Wahidin. Jangan Wahidin gede, yang kecil. Oh, Wahidin gede. Jadi Wahidin deh, Wahidin. Wahidin.
Hah? Iya makanya.
Ada rumah sakit Wahidin. Selamat siang.
Iya.
Mana
Siang.
gambar? Oh, gambarnya nggak ada.
Selamat siang.
Gede. Iya, selamat siang Bu. Kedengeran sekali. Sama Bu, mohon izin Bu. Siapa Bu? Siapa ya?
Saya dengan Dr. Andi Pratiwi. Kebetulan kemarin ikut pelatihan yang gelombang 4.
Oh ya. Sebentar dok, saya lagi lihat. Nah ini dia pakai masker hijau. Ya silakan. Dokter Andi Pratiwi, kondisinya kayak apa sih di Wahidin? Karena kami berharap sekali dalam waktu yang dekat ini data-data kanker itu bisa terkumpul gitu loh. Nah, apa yang mesti kita lakukan nih? Silakan dok.
Ya, terima kasih. Kalau kami sendiri di Wahidin sebenarnya memang sudah ada tim onkologi sebelumnya, tapi sepertinya akan dilakukan revisi kalau terakhir info dari manajemen. Kemudian terkait untuk registrasi kankernya, sebenarnya sebelumnya sudah pernah ada setahu saya yang mengikuti pelatihan ini sebelumnya di tahun 2000, di bawah 2018 kalau nggak salah, 2017 apa 2018, dan ya, jadi sudah pernah ada laporan kanker. Kalau terkait laporan yang kemarin saya dapat sih, sudah pernah ada registrasi kanker sebelumnya, terakhir tahun 2020 apa enggak ya? Jadi untuk yang 2000 ya mohon koreksinya ya Pak Bu kalau memang salah info yang saya dapatin. Jadi kalau untuk yang tahun di atas 2020 kayak 2021, 2002 itu memang sementara saat ini belum berjalan kemarin. Jadi mudah-mudahan setelah kami ikut lagi yang baru-baru ini, yang pelatihan ini, kita mudah-mudahan bisa melakukan registrasi kembali untuk data-data yang tertinggal kemarin. Seperti itu kondisi yang sekarang. Terima kasih.
Terima kasih dok. Ya mudah-mudahan dikawal terus bisa semakin bagus ya. Karena ini kedepannya kita akan makin intens lagi nih terkait dengan data kanker ini ya dok ya. Tolong disampaikan ke direksinya. Nanti saya juga akan ngobrol lewat Arfi ya.
Baik, terima kasih.
Terima kasih. Silakan Rumah Sakit Al Ihsan terakhir.
Assalamualaikum warahmatullahi wabarakatuh. Izin Pak.
Ya silakan Pak. Waalaikumsalam.
Ya, mungkin kendala yang kita hadapi untuk saat ini sama tadi kayak yang sebelumnya Pak. Karena kita kan selama 2020 itu tidak pernah mengikuti pelatihan lagi perihal si register kanker ini Pak. Jadi baru ada lagi yang kemarin-kemarin itu, yang terakhir itu. Nah dari situ kan kita harus melaporin itu Pak dari 2018, 19, 20 itu agak kerepotan gitu Pak. Jadi karena dengan banyaknya variabel yang harus kita isi, ya itu yang menjadi kendala kita gitu. Jadi mungkin kemarin dari pelaporannya kita belum maksimal gitu Pak untuk pelaporannya seperti apa. Sebenarnya kalau dari segi kalau kita dikejar misalnya satu-satu atau seperti apa dirunut gitu ya, sebenarnya tidak akan menjadi susah seperti apa gitu, karena kita tadi punya PR yang tahun-tahun sebelumnya, itu yang menjadi kendala kita gitu Pak dalam pelaporan seperti apa gitu.
Kalau misalnya nih dalam 1 bulan ke depan kami mencoba untuk mengumpulkan data kanker registry dari Rumah Sakit Al Ihsan, sejauh mana kira-kira bisa diusahakan itu Pak?
Kalau untuk yang maju ke depannya bisa Pak diusahakan itu.
Ya.
Kalau untuk sebulan ke depannya tadi itu bisa Pak.
Ya, oke. Jadi ke depannya kita sama-sama komitmen untuk menyelenggarakan ini ya Pak ya, demi tadi kan
Pak
Indonesia nih yang aman itu.
Ya.
Oke, terima kasih RSUD Al Ihsan sukses selalu. Ya.
Ya Pak, sama-sama Pak.
Terakhir mungkin ada yang ingin komentar atau ingin curhat di sini, silakan dari rumah sakit. Ya, kalau coba lihat sekali lagi, nggak ada yang raise hand. Saya hitung sampai 10 ya. Itu agak mana di pada dulu. Ya sudah, terima kasih Bapak Ibu semua. Selalu semangat ya dengan situasi transformasi pelayanan kesehatan sekarang ini. Saya kembalikan kepada moderator.
Thank you. As we come to the end of our event today, we would like to express our gratitude to each and every one of you for your presence, active participation, and valuable contribution throughout the day. Because appreciation to our esteemed speakers, Mr. Lesteri, our President Director, Dr. Suko Wedindito, and Evelina Suzana MD, for sharing their expertise and knowledge with us. Your contributions have provided us with valuable insights and inspiration for the development of cancer registration system. To all the participants, thank you for attending this event. We hope that the discussion and insights shared today will pave the way for brighter future in cancer registry development. Thank you once again for being part of this meaningful gathering. Good afternoon. Wassalamualaikum warahmatullahi wabarakatuh.
So we hope that there will be a bright side for cancer in Indonesia, just like this packet.
Satu, dua. Oke.
Ya, foto bareng. Pak, foto bareng.
Put this